gross observation of bone based on their external morphology, bones are categorized as long bones composed of a slender shaft, diaphysis, and two heads, epiphyses. Short bone. Long bone. Width bone. Flat bones composed of two flat plates of compact bone sandwiching a layer of spongy bone. Irregular bone. Sesamoid bones. Formed within the substance of tendons based on density, one bone may be dense, as in compact bone. Two spongelike, as in Cancellous, spongy bone. Spongy bone is always surrounded by compact bone. The marrow cavity of long bones, lined by a thin layer of Cancellous bone, houses red marrow in young individuals, but it accumulates fat deposits as one ages and becomes known as yellow marrow in adults. Red marrow produces blood cells, whereas yellow marrow does not produce blood cells, but does retain its hematopoietic potential. Cancellous bone has resting osteoblast-lined marrow spaces that contain red marrow, and the bone tissue that forms the perimeter of the marrow spaces has smaller and larger irregular lamellae of bone. Spicules and trabeculae. The articulating surfaces of the epiphyses are composed of a thin layer of compact bone that overlays spongy bone and is covered by hyaline cartilage. In individuals still growing, an epiphyseal plate of hyaline cartilage is interposed between the epiphysis and the diaphysis. The metaphysis is a flared zone of the shot, located between the diaphysis and the epiphyseal plate. The external surface of the diaphysis and the non-articulating surfaces of the epiphyses are covered by a two-layered periosteum that is inserted into the bone via collagen fibers, Sharpie's fibers. The outer fibrous layer of the periosteum is composed of dense irregular fibrous connective tissue whose neurovascular elements serve the outer region of compact bone. The inner cellular layer possesses osteoprogenitor cells and osteoblasts. Bones of the calvaria, skull cap, are composed of the outer and inner tables of compact bone with a layer of spongy bone known as the diplo interposed between them. The periosteum covering the outer table of the bones of the cranium is known as the pericranium, but the periosteum covering the inner table of the bones of the calvaria is the Dura Mater, the outermost layer of the meninges covering and protecting the brain. The dura also serves as the periosteum of the inner table. Bone types based on microscopic observations. Two types of bone may be observed from microscopic studies: primary bone and secondary bone. Primary bone, immature or woven bone, is the first bone to be formed, and it is the bone formed initially during bone repair. Primary bone is more cellular, it is less calcified, and its collagen fiber arrangement is haphazard. It is replaced by secondary bone except in the alveoli of teeth and tendon insertions. Secondary bone, mature or lamellar bone, is highly organized into concentric bony lamellae, 3 to 7 gym thick, and because it is more calcified and has a precise arrangement of collagen fiber bundles, it is stronger than primary bone. Osteocytes housed in lacunae are distributed at regular intervals between, or infrequently within, lamellae. These cells communicate with one another via their osteocytic processes that form gap junctions with each other in narrow channels known as canaliculi. Lamellar systems of compact bone. Compact bone consists of very thin bony layers called lamellae, arranged in 4 lamellar systems: outer and inner circumferential lamellae, interstitial lamellae, and osteons, Haversion canal systems, that are readily observable in long bones. The outermost calcified layer of the diaphysis, located just deep to the periosteum, is the outer circumferential lamellar system, into which Sharpie's fibers insert. Lamellae of bone that encircle the marrow cavity are known as the inner circumferential lamellar system. Spongy bone lining this lamellar system extends trabeculae and spicules into the marrow cavity. Lamellar systems of compact bone, cont. Haversion canal systems, osteons, about 20 to 100 gym in diameter, constitute the predominant lamellar system in compact bone. Osteons are composed of wafer-thin lamellae of calcified bone that form concentric cylinders whose central, Haversion canal contains a neurovascular supply and are lined by osteoprogenitor cells and osteoblasts, Fig 7.6. As the vascular supply branches and bifurcates, Osteons mirror this organization. Osteons are delimited by a boundary, known as a cementing line, composed of calcified ground substance containing only few collagen fibers. The helical arrangement of collagen fibers is strictly organized, so that, when viewed in cross-section, the fibers parallel each other within a particular lamella, but are perpendicular to collagen fibers of adjacent lamellae. This pattern is created by varying the pitch of the helix, lessening the chances of bone fracture. Haversion canals are connected to the canals of their neighboring osteon via oblique channels, Folkman's canals, which allow blood vessels access to other Haversion canals. Osteons are formed as follows: the outermost lamella, the one bordering the cementing line, is formed first, succeeding lamellae line the last one that was formed, and the innermost lamella, bordering the Haversion canal, is the last one to be formed. Because chapter osteocytes depend on the inefficient canaliculi for their sustenance, the thickness of each osteon is limited to approximately 20 lamellae. Bone is being continually remodeled as osteons are resorbed by osteoclasts and are replaced by osteoblasts. This process leaves remnants of the old osteons, which appear as arc-shaped fragments of lamellae, known as interstitial lamellae, trapped among unresorbed osteons. Histogenesis of bone. Bone develops in the embryo either by intramembranous bone formation or by endochondral bone formation. Although these two methods are grossly different, histologically, the final products are indistinguishable from each other. Regardless of the mode of development, primary bone is the first to form. This is resorbed and replaced by secondary bone, which is mature bone that continues to be resorbed and remodeled as it responds to environmental forces placed on it throughout life. Intramembranous bone formation is the method by which most of the flat bones develop. Formation begins in a highly vascular environment of mesenchymal tissue in which mesenchymal cells maintain contact with each other. These mesenchymal cells express the osteogenic master regulators, transcription factors SPA1/RUNX2 and the zinc finger transcription factor Osterix, and differentiate into osteoblasts, which secrete bone matrix. In the absence of Osterix, the mesenchymal cells differentiate into preosteoblasts, but cannot make the transition into fully competent, matrix-secreting osteoblasts. Osteogenesis begins as the initial matrix forms trabecular complexes whose surfaces are occupied by osteoblasts. This area now represents a primary ossification center forming primary bone. When osteoid is secreted, calcification begins trapping osteoblasts in lacunae. These cells, surrounded by their matrix, are now known as osteocytes. The matrix calcifies, and canaliculi are formed around processes of osteocytes. Trabeculae enlarge and increase in number, forming networks around the vascular elements, which become transformed into bone marrow. Additional ossification centers are necessary in the larger flat bones, such as those of the skull. As bone formation continues, these ossification centers fuse, forming a single bone. An exception is in the fontanelles of the newborn skull, where the ossification centers of the frontal and parietal bones do not fuse until after birth, when the membranous soft spots are replaced by bone. Regions of the mesenchymal connective tissue that do not participate in bone formation become transformed into the periosteum and endosteum. Endochondral bone formation. With the exception of the flat bones, most of the bones of the body are developed via endochondral bone formation, a method employing several phases. These processes are presented graphically in figure development of bone. As the bone being formed becomes stable to support the body, the cartilage model is resorbed and replaced by the forming bone. The first area of the cartilage model to be replaced is the diaphysis, the primary center of ossification, to be followed by bone formation in the epiphyses, the secondary centers of ossification. The process of endochondral bone formation is represented by a dynamic sense of interrelated events that begin in fetal life and continue into adulthood and beyond, as bone may need repair. Even in adulthood, these processes are in action, as bone is in a dynamic state and must be remodeled constantly to accommodate environmental forces. Bone growth in length. The proliferation of chondrocytes located in the epiphyseal plate is responsible for bone elongation. The epiphyseal side of the plate is cartilaginous, whereas at the diaphyseal side of the plate, bone is replacing cartilage. The epiphyseal plate presents 5 distinct zones beginning at the epiphyseal side of the epiphyseal plate as follows: Fig 7.9 Zone of reserve cartilage, mitotically active chondrocytes are haphazardly arranged. Zone of proliferation, chondrocytes secrete the protein Indian hedgehog, which hinders hypertrophy of chondrocytes and induces the release of PTH-related protein, PTHrP, which promotes cell division among the chondrocytes of the zone of proliferation. The proliferating chondrocytes form parallel rows aligned in the direction of bone growth. Zone of maturation and hypertrophy, maturing chondrocytes amass glycogen and express the transcription factors SPFL/RUNX2, which permits them to hypertrophy. These chondrocytes also release type X collagen and vascular endothelial growth factor, which promotes vascular incursion. Chapter Zone of calcification, hypertrophied cells attract macrophages to destroy the calcified walls between their adjacent, enlarged lacunae. Chondrocytes undergo apoptosis and die. Zone of ossification, osteoprogenitor cells enter the zone of ossification and form osteoblasts, which deposit bone matrix that becomes calcified on the surface of the calcified cartilage. The calcified cartilage/calcihead bone complex becomes resorbed and is replaced by bone. Bone continues to grow in length as long as there is a balance between the zone of proliferation and the rate of resorption in the zone of ossification. By the time the individual reaches 20 or so years of age, the mitotic rate in the proliferation zone is surpassed by the resorption rate in the zone of ossification, depleting the zone of reserve cartilage. When the last calcified cartilage/calcified bone complex is resorbed, the epiphyseal plate no longer separates the epiphysis from the diaphysis, the marrow cavities of the two regions become continuous, and the bone is unable to continue growing in length. Bone growth in width. Bone growth in length occurs by interstitial growth of the cartilage of the epiphyseal plate, whereas bone growth in width is accomplished by appositional growth occurring deep to the periosteum. Osteoblasts derived from osteoprogenitor cells of the periosteum secrete bone matrix on the bone surface, a process known as subperiosteal intramembranous bone formation, which continues during bone development and growth. Throughout life, the processes of bone resorption and bone deposition must be in balance. Bone formation on the external surface of the diaphysis must be balanced with osteoclastic activity resorbing the internal aspect to enlarge the marrow cavity. Calcification of bone. Although the process of calcification is not fully understood, it is known that proteoglycans, osteonectin, and bone sialoprotein stimulate calcification. The calcification theory currently accepted involves release of membrane-bound matrix vesicles, 100 to 200 nanometers in diameter, by osteoblasts. Matrix vesicles contain high concentrations of Ca and PO4 ions, adenosine triphosphate, ATP, alkaline phosphatase, cyclic adenosine monophosphate, ATPase, pyrophosphatase, calcium-binding proteins, and phosphoserine. Matrix vesicle membranes have calcium pumps that transport Ca ions into the vesicle. Increased concentrations of Ca ions cause the formation of calcium hydroxyapatite crystals that grow in size and eventually puncture the vesicle membrane, causing it to disperse its contents. Freed calcium hydroxyapatite crystals serve as nidie of crystallization within the matrix. Enzymes released from matrix vesicles liberate phosphate ions that combine with calcium ions and calcify the matrix around the nidie of crystallization. Water is resorbed from the matrix, and hydroxyapatite crystals are deposited within the gap regions of the collagen molecules. The various nidie of mineralization enlarge and fuse with each other, and the entire matrix becomes calcified. Bone remodeling. 90 Adult bone is remodeled constantly, and Haversion systems are continuously being replaced to counter the changing environmental stresses placed on it, as some bone is resorbed from one area, and some bone is added to another area. The generalized shape of bones continues to mirror the form of the embryonic cartilage templates, even though they are many times larger than their embryonic counterparts. This ability is a product of surface remodeling because bone deposition and bone resorption act in concert on the periosteal and on the endosteal surfaces of bone. Cells of compact bone respond to the systemic factors calcitonin and PTH, whereas cancellous bone is remodeled in response to local bone marrow-derived factors, such as colony-stimulating factor 1, tumor necrosis factor, interleukin-1, osteoprotogerin, OPG, a rank homolog, osteoprotogerin ligand, OPCL, a rank L homolog, and transforming growth factor DASH. When Haversion systems are replaced, the osteocytes die, and some portions of the old Haversion systems are resorbed by osteoclasts, whose activities create resorption cavities. As osteoclastic activity is continued, the resorption cavities enlarge and become invaded by blood vessels. Cartilage bone formation begins as osteoblasts manufacture successive lamellae surrounding the blood vessels, forming a new Haversion system. This resorption followed by bone replacement is known as coupling. The remnants of resorbed osteons remain as the interstitial lamellar system. Bone repair. When bone injury is severe, the ends of a broken bone may be displaced or bone fragments may be detached from the injured bone or both. Addition ally, blood vessels are severed near the break, causing localized hemorrhaging, forming a blood clot that fills the injury site. Blood supply to the region ceases retrograde from the injury site back to where anastomosing vessels may later develop collateral circulation to the region. Many Haversion systems lose their vascular supply, which causes their osteocytes to die, resulting in empty lacunae and enlarging the zone of injury. The periosteum and the bone marrow are less affected by this loss of a vascular supply because their tissues are exceptionally well vascularized from many areas. Within 2 days of injury, small capillaries and fibroblasts invade the blood clot that fills the injury site and form granulation tissue. The osteogenic layer of the periosteum, endosteum, and undifferentiated cells of the bone marrow proliferate, forming osteoprogenitor cells, which differentiate into osteoblasts. The newly formed osteoblasts secrete bone matrix cementing dead bone in the injury site to the healthy bone, beginning the formation of a collar of bone, the external callus. Concurrently, the clot within the marrow cavity is invaded by multipotential cells of the bone marrow and by osteoprogenitor cells originating from the endosteum to form, within less than 1 week after injury, the internal callus composed of bony trabeculae. Proliferation of osteoprogenitor cells in the region of the external callus outpaces the growth of capillaries. Some of the osteoprogenitor cells located farther away from the capillary bed are exposed to a reduced oxygen tension. These cells become chondrogenic cells that differentiate into chondroblasts and secrete cartilage matrix on the surface of the bone collar. Osteoprogenitor cells that are still in the presence of capillaries continue to proliferate, forming more osteoprogenitor cells. The external callus is composed of 3 layers: layer of bone collar cemented to bone, layer of cartilage forming an intermediated layer, surface layer containing osteogenic cells. Cartilage matrix adjacent to the woven bone of the collar becomes calcified and is ultimately replaced with primary bone via endochondral bone formation. Eventually, all of the bone fragments become united by cancellous bone. Finally, the injury site is remodeled by replacing the primary bone with secondary bone and resorbing the callus. The injury zone ultimately is restored to its original shape and strength. Intramembranous and endochondral bone formation are necessary for successful repair of bone fractures. When bone is damaged so severely that it may be necessary to remove some of its fragments, the distance between the remaining bone segments may be too great to form a callus bridge and form a bony union. In this instance, viable bone for grafting is secured from a bone bank where bone is harvested and frozen to maintain its osteogenic potential. 3 different kinds of bone for grafting are available. Autografts are grafts of bone from the recipient and are the most successful. Homografts are grafts of bone from another individual of the same species. These pose risks of immunological rejection. Heterografts are grafts of bone from a different species and are the least successful. Androgens and estrogens produced by the male and female gonads influence skeletal maturation by affecting the closure of the epiphyseal plates. Skeletal development is stunted when sexual maturation occurs early because this stimulates the epiphyseal plates to close prematurely. The opposite is true in individuals whose sexual maturity is retarded. Skeletal growth in these individuals continues for a longer time because their epiphyseal plates remain functional beyond the normal time frame. Osteoporosis is related to decreasing bone mass and affects about 10 million Americans, especially postmenopausal women and women older than 40 years. The decreased estrogen production by these women reduces the number of osteoblasts recruited to secrete bone matrix. Additionally, osteoclastic activity is increased beyond that of bone deposition, resulting in a decreased bone mass. The severity of the reduction may be great enough that the affected individual's bones become fragile. To ameliorate the disease process, estrogen replacement therapy was initiated in these women. It was discovered, however, that estrogen replacement therapy increased the risk for heart disease, breast cancer, stroke, and blood clots. Consequently, instead of estrogen replacement therapy, a new group of drugs, bisphosphonates, are employed to reduce the incidence of osteoporosis-induced fractures. Maintenance of blood calcium levels. Calcium levels in the blood are carefully controlled and maintained at a blood plasma concentration of 9 to 11 mg/dl. The body's reservoir for calcium is in bone, where about 99% of the body's calcium is stored in hydroxyapatite crystals. The remaining 1% is available for rapid recruitment from newly formed osteons whose labile calcium ions are more readily available. A constant exchange occurs between calcium ions present in bone and those in blood. Hormonal effects. When blood calcium levels decrease, the parathyroid glands secrete PTH, activating osteoblasts to secrete osteoclast-stimulating factor and OPCL and to cease bone formation. As a result, dormant osteoclasts are activated, and the formation of new osteoclasts is induced, initiating bone resorption and ultimately leading to calcium ions being released from the bone and transferred to the bloodstream. Chapter Plasma calcium ion levels are monitored by parafollicular cells, C cells, of the thyroid gland. Increased levels of calcium ions in the plasma prompt these cells to secrete calcitonin, a hormone that sensitizes receptors on the osteoclasts, restraining them from resorbing bone. At the same time, osteoblasts are signaled to increase osteoid synthesis, and calcium is recruited and deposited in newly forming bone. The anterior lobe of the pituitary gland secretes somatotropin that controls bone development by encouraging insulin-like growth factors, formerly called somatomedin, which stimulate epiphyseal plate growth. Additional factors affecting bone metabolism are, interleukin-1, derived from osteoblasts, activates proliferation of osteoclast precursors and indirectly stimulates osteoclasts. Interleukin-6, derived from bone cells, induces the formation of new osteoclasts. OPG restrains osteoclast differentiation. Tumor necrosis factor, formed by activated macrophages, resembles interleukin-1 in function. Interferon Y, formed by T lymphocytes, prevents the formation of osteoclasts. Colony-stimulating factor 1, formed by stromal cells, stimulates osteoclast formation. Transforming growth factor - released from bone matrix during bone degradation induces osteogenesis and inhibits osteoclast formation. In addition to hormones, vitamins also aid skeletal development, Table 7.4. Joints. A bone may articulate with another bone at a movable joint, or two bones may closely approximate each other in a non-movable joint. Classification of joints is based on whether there is a lack of movement, synarthrosis joints, or there is freedom of movement, diarthrosis joints, between the two bones of the joint, Fig 7.11. Synarthrosis joints are of three types: synostosis, minimal or no movement, bone is joint uniting tissue, example right and leparietal bones of the adult skull. Synchondrosis, only a limited amount of movement, hyaline cartilage is joint uniting tissue, example sternocostal joint. Syndesmosis, little movement, dense connective tissue is the joint uniting tissue, example inferior tibiofibular articulation joined by the interosseous ligament. Diarthrosis joints are the most common joints of the extremities, see Fig 7.10. The articulating surfaces of the bones of these joints are permanently covered by hyaline cartilage, articular cartilage. Contact between the bony members of the joint is usually maintained by ligaments that are attached to both bones of the joint. A joint capsule encloses and seals the joint. The outer fibrous layer of the capsule is composed of dense connective tissue, which becomes continuous with the periosteum of both bones of the joint. The inner layer of the capsule, the cellular synovial layer, synovial membrane, covers all of the joint surfaces except the articulating surfaces. The synovial layer is composed of two cell types. Type A cells are macrophages that phagocytose debris present in the joint cavity. Type B cells secrete synovial fluid. Synovial fluid supplies nutrients and oxygen to the chondrocytes of the articular cartilage. It possesses leukocytes, a high concentration of hyaluronic acid, and lubricin, a glycoprotein that is combined with plasma filtrate to lubricate the joint. Osteoarthritis is a degenerative disease of the synovial joints related to wear and tear on the articular cartilage of the condyles of one or both bony members of the joint. The hyaline cartilage begins to degenerate and eventually erodes, and the cortical bones of the condyles contact each other during articulation, causing pain severe enough to restrict movement at the joint and debilitate the individual. Rheumatoid arthritis is a disease of synovial joints related to destruction of the synovial membrane. The synovial membrane becomes thickened and infiltrated with plasma cells and lymphocytes. The articular cartilage is eventually destroyed and replaced with fibrovascular connective tissue, resulting in severe pain during movement at the joint. Cartilage rickets is a disease of infants and children caused by vitamin D deficiency. When vitamin D is absent, the mucosa of the intestines cannot absorb calcium even when the diet is adequate. Without calcium there are bone ossification disorders in the epiphyseal cartilages and confused orientation of metaphysis cells, resulting in insufficiently calcified bone matrix. Rickets causes a child's bones, especially those of the legs, to be deformed and weakened because the bones can no longer bear the body weight. Osteomalacia is a prolonged vitamin D deficiency disease in adults, adult rickets. When vitamin D has been absent for an extended time, newly formed bone in the remodeling process does not calcify in a proper fashion. During pregnancy, this condition may become severe for the woman because the fetus requires calcium, and the only source for the fetus is from the mother. Scurvy is a vitamin C deficiency disease. When intake of vitamin C is inadequate, there is deficient collagen production, resulting in inadequate formation of bone matrix and bone development. This condition is also problematic because healing is delayed in the absence of proper levels of collagen.